and subsequently we'll carry on with the others. So I would invite Mr. Shri Mishra. Kindly welcome him. Thank you.
Thank you, Devji. Mr. Khitan, Mr. Sanat Kumar, Mr. Patnaik, Mr. Varendra Sinha, Mr. Kirotra, Mr. Sethi, Mr. Devji Talapatra, members of the chambers, ladies and gentlemen, and distinguished personalities who are present here. First and foremost, a big thank you to the chambers for A, having organized this, and B, and more importantly, having invited me to this. It's a pleasure to be here, and pleasure to also be a part of the entire discourse, which is going to have a great impact on the healthcare delivery systems. In fact, when Mr. Devji Talapatra was trying to persuade me to come here and I was resisting, he threw in a bait. He said, this is the first of the things that we are doing and you must participate because subsequently we want to do a healthcare summit. And I thought it was a very good idea for the chambers to do a healthcare summit where, of course, the Ministry of Health will partner to make sure that we have a decent gathering and a decent discussion in the healthcare summit that we propose to have. So that was one of the motivations, apart from the discussions today, to be here. To be very honest to you, when you talk about health insurance, I have extremely limited knowledge on the insurance part, and perhaps a little knowledge on the health part. What I do know is what impact financing in various forms, including insurance, would really have on healthcare delivery systems in a country like India. Because you are discussing this on the landscape of the fact that you have one of the largest populations, perhaps amongst the highest disease burdens, and also the fact that at the end of the day it is 26 million children being born every year who need health care. So whatever you discuss in terms of healthcare financing and health insurance really is to address the standard healthcare needs of every Indian today, which itself is not just vast but also very, very complex and complicated. And given the fact, as Mr. Varendra Sinha was just mentioning, the penetration is very low. We need to seriously discuss and debate today as we go along, and unfortunately I won't be here, and my apologies, of course, for having changed the schedule, etc., etc. To be very honest, I'm not to be blamed. But sorry for that. But when you discuss today, one of the things that you really must look at is how critical is health insurance. More than that, what is the point of intervention where we need this insurance most? Healthcare is a spectrum and a huge one. Where do we really need the intervention of health insurance in the Indian context? In the context of USA, for example, it's a completely different story. Because what is it that you do? I mean, if you look at, let's say, the 2017 National Health Policy that has just come out, we are looking at three basic pillars: accessible, affordable, quality healthcare to everyone. And in this entire matrix that you draw up, there are several players who would contribute to getting there. And one critical player would be health insurance. With India traditionally did not have a very strong health-seeking behavior, particularly in the slightly less educated and the unreached population. But as we grow, and with rising incomes and growing awareness in many ways, and also increase in the lifespan, the health-seeking behavior is continuously increasing, which means the burden on the system to provide healthcare is on the rise. Now, one of the things that has also happened is when you have a longer lifespan, health issues cross a particular age, when you have also aging population, are very, very complex. India has a very strange scenario where you have 253 million adolescents who have a completely different set of health needs. And you have a huge older population which has a completely different health need. So you have to somehow find a marrying point between the two where you deliver. But the bottom line is that you need in this scenario to reach out to everyone. And one very critical thing is, how do you finance the entire thing? In many of the countries in the world today, much of the financing is public health financing, which comes from the government. And in many of the better run health systems, this is true. In India, just to make a minor correction on the figures that were given out, today we spend about 1.04% of our GDP, that is the public health spend, by all governments put together, central and state governments put together. The 2017 policy says by 2025 we'll take it to 2.5%, which roughly in terms of rupee, if you ask me, today states and centre put together spend about 2 lakh crores. It will go up to about 8.5 lakh crores by 2025, which is a huge ask. But even then, it may not be enough to take care of the health needs. So where will it come from? It either comes from government, or is covered by insurance, or comes from the pocket of the person who needs the healthcare. That brings me to the point of the entire exercise being in the direction of reducing out-of-pocket expenditure for healthcare needs. Today, the out-of-pocket expenditure in India, and again a minor correction to the figures that were read out, is about 58% to 60%, which incidentally makes India rank 183 out of 189 countries. It's as high as that. Even if we go to 2.5% of funding, even then we will not be able to really reduce the out-of-pocket expenditure at the speed and the pace that we want to do it. Therefore, insurance is very critical in filling that gap, which will actually pull down the out-of-pocket expenditure. It's a very sorry state of affairs when 7 crore families every year it's estimated that they fall back into poverty because of health needs, particularly due to what they call catastrophic health expenditure. But in this entire debate of out-of-pocket expenditure, hospitals, Mr. Virendra Sinha was talking about private hospitals being very expensive. That's not the only part of the story. Look at where they are located. Look at where the population is. There's a complete mismatch. I mean, you can't see healthcare in terms of needs of metros. Today, non-communicable diseases form the largest part. There was a feeling earlier that this is a rich man's burden. It's not. We have equal number of diabetic and hypertensive patients in the field. I mean, field meaning the rural areas. And even look at the common causes of cancer, particularly 2 of them, cervical cancer and oral cancer. The incidence in the rural area is much higher than what it is in the urban. There are reasons for it. There are social reasons for it. There are reasons of hygiene. There are reasons of lifestyle, everything put together. But the fact remains that as a country we need to address these needs. And far more penetration from the insurance sector is required. So there are two things in this. The challenge is to bring in those resources to take care of the health care needs. And for the insurance sector, the opportunity is the rising healthcare needs and the health-seeking behavior. So we really from the government need to create a situation where we are able to get the insurance sector to easily come to the assistance of those who need healthcare business. You know, I have a point of view which is not often shared in forums like this. In forums like this, much of the talk is about beds, is about pathology, it's about radiology, it's about surgery, it's about hospitalization. But let us pause for a moment. The way the population is growing, or the kind of numbers that we have in this country, you can never have enough healthcare, secondary or tertiary healthcare facilities for people, no matter what your level of investment. So we as a country should debate where the investments of government, private sector insurance should lie. Should it lie in healthcare or should it lie in hospital care? To me, the critical place where investments and interventions must lie is healthcare and not hospital care. I was recently having a discussion with one of the ambassadors of a smaller but a very prosperous country. And during the course of discussion, one of the things he told me was that one of our biggest pride today is that we have lowest population to bed ratio in the world. To me, that is the healthcare system that we need. Yes, there will be need for secondary and tertiary care and we must cater to that. But as a country, we need to look at healthcare financing and insurance in sectors which is preventive and promotive, and that is the primary healthcare essential. And see, no matter how much of subsidy you are going to give to hospitals, the cost of treatment is not just a factor of investment. It's a factor of several complex things which put together healthcare. So unless that entire gamut of activity is really attended to, we will not be able to do this. In its own small way, Government of India started the RSBY, the Rashtriya Swasthya Bima Yojana. Coverage of only 30,000 rupees, but fairly widespread. And our colleagues from the government insurance sector would know that even that has proved to be very difficult. Of a total possible coverage of about 11 crore families, so far we've only been able to reach about 3.75. So that is the kind of coverage that we have today. The private sector insurance penetration is even lower. And there are many issues. The insurance people will tell you why it is happening. And what is the return and what is the payout and all those things they will discuss. But the critical issue is, unless this form of financing comes into healthcare delivery, pocket expenditure for the country, and therefore this whole drum of people going back into poverty will not be prevented. And the entire insurance sector should look at their role in this overall scenario. It's not just about curing a person. It's about taking care of a system. And it's a far more, critical intervention that you're making there. When we did RSBY, suddenly many of the states took off. And today, at least 21 states have their own insurance schemes whether run through insurance companies or through trusts, which offer a coverage of 2 to 3 lakhs to 4 lakhs. And these states have been doing extremely well. A couple of the states, I will not name them, I have always cautioned them that getting into the insurance should not mean that your investment goes to insurance sector and you reduce your expenditure on public health. The strength of the government lies in providing very good public health and primary care. What is left from there, because then you reduce the burden on tertiary care, what is left from there needs to be taken care of by insurance and other entities. But then, given the financing pattern today in healthcare provisioning, there is no way you can ignore a segment of insurance which is so critical if you really want to reduce the out-of-pocket expenditure. And government has been trying to talk to people, see what are the constraints so that we are able to remove that and move ahead with it. But if you look at the 2017 policy, the commitment is very clear. The out-of-pocket expenditure for an average Indian must come down heavily. And we need to together work in that direction. Such discussions will certainly throw light on what are the interventions that are required, what are the policy changes that are required, or the newer programs that we need to roll out that are required. We will be extremely happy to hear about them. Unfortunately, I may not be able to be here to hear everyone, but I'm sure the chambers will be kind enough to provide me with a synopsis of what was being said, so that we in government, when we take a decision, we take that into account. Today, the Ministry of Health has been telling every forum that we don't want a policy, healthcare policy in India which is completely government driven. It has to just be a policy which is government led, and we need partnerships from every other part of the industry, including the insurance sector, and I'm sure we will have it. And sure enough, by 2022, when the Honorable Prime Minister says that we must change things on the 75th independence of the country, we will have a new scenario where the penetration will be much better and the penetration will be far more effective. And of course, I do hope that this entire exercise is patient-centric and not hospital-centric. Thank you very much.
One of the questions, sir, is that in insurance we have a lot of data and information that is publicly available, public disclosures, so on and so forth. But in the hospital system, we don't have that. We don't know the doctor performance rates, the rate cards of different hospitals, and so on. So have you ever thought about that?
See, this is a major crisis, particularly with reference to the private sector. We've not been able to evolve a uniform norm for the entire country. We are thinking of coming up with that. I mean, the government of India did enact a law which would, kind of suggest that every segment, every hospital maintains this, but we've not been able to enforce it. Patient data you will get from various sources, but you're right. I mean, in terms of the hospital's ability to perform in the hospital's performance level or their own rating or rates also, they are not really available. And I would admit the system is a bit opaque today. We really need to work on that.
Sir, can you just elaborate on this uniform norms that you have just alluded to? Like by when these norms will be put into public domain, bit of detailing so that we get some perspective on that. Thank you.
See, we in government have prepared what is known as the standard treatment guidelines, which is already in public domain, but that does not get into the cost of treatment. With industry, CII and FICCI, for a long time we've been trying to work out a mechanism by which we can actually do a cost of treatment for certain forms of treatment. We haven't really succeeded for the simple reason that on many of the hidden costs we have no agreement. But to ensure adherence, there is a Clinical Establishment Act. Unfortunately, only 10 states in the country have adopted that. It's a central act which needs adoption by the state governments, where state governments then get empowered to fix all these in consultation with the hospitals and display that. Having said that, it's not a very easy thing to do. And just to share with you, one new event that has taken place is the West Bengal enactment. And we are still waiting to see how it plays out so that we are able to. But Clinical Establishment Act is a good tool. And I do feel that ultimately at the end of the day, if there is enough competition in the private sector, we will not need to tell the private sector to reveal all this. It will come automatically. Right now, the supply side is a little weak.
I believe we have builders on live with us over here. Yes, Mr. Ajay Kumar. Yeah, you had a question. And Mr. Sethi, you would take the last question.
Yeah. However, the resources are not there for the entire people to take care of. So why not we work something like building a health fund, a product which can build a health fund, probably which can take care of somebody which is in the hour of need.
Then that risk pool goes into different segments, including older population, etc., etc. In India, we do have a senior citizens fund, but we have not been able to use that very effectively. In fact, only last year we introduced, along with the RSVY, a senior citizen insurance scheme in India for the population, which the family members of the RSVY beneficiaries. So we are moving in that direction, but I don't know if there is clarity still on creation of a common fund for that. Perhaps that is one of the answers that may lie in future.
Thank you. Yeah, one question, Mr. Sethi. That's the last one.
Sir, in the recent years, we have gone into an era of regulators, electricity, aviation, so and so, so and so. One of the need of this country has been to have healthcare regulator, which will take care of healthcare education, healthcare providers, pharma, health insurance. These are coming under different ministries. Let HR ministry take care of Sanskrit education. Let healthcare regulator take care of healthcare education, which is very much needed. What is the thought process? What is stopping the formation of healthcare regulator in this country, and whether we will have it in the coming 1 or 2 years so that 2022 objective is achieved?
Well, thank you for the question. That gives me a bit of strength, because I thought it would be an anathema to a crowd like this to have a regulator. But 2017 policy talks about it. And there is a thinking going on, because once you move towards electronic health records and it is universally applied, there are several issues of privacy, rights, etc., which will come up, including costing healthcare needs. And then perhaps you will need a regulator. I would have ideally finished it, but I don't want to be unfair. I mean, the only lady who's been raising her hand, you've not even been looking at her. That's not fair.
I'm so sorry.
Go ahead with the question.
She is Tina Jain. I must welcome you. She is Tina Jain. She is editor of India
Money
Today.
Today.
India Today. Money. She is editor.
Sir, I wanted to ask you about Rashtriya Swasthya Bima Yojana. Since universal health insurance scheme is going to be rolled out, what will be the status of Rashtriya Swasthya Bima Yojana after that?
RSVY in many sense is a precursor to the National Health Protection Policy that we are talking about. And in the new frame that we have created, RSBY gets merged into that. We will not run two schemes, it will be one scheme. And the beneficiaries of RSBY will automatically get transferred to the NHBs.
When is it going to be implemented? Any date we can look at?
I'm as eagerly waiting as you are. Thank you very much. Thank you. Thank you.
Thank you, and a big round of applause for the second.